biases in terms of treatment. You've heard a lot of the facts, a lot of the details, so these are personal biases. In claudication, historically, we started off in the 60s with the knowledge that as vascular surgeons we could save the world. We could put bypasses into everybody with claudication and they'd all feel better. And to a certain extent, we put any old bypass in, and a large number of above-knee PTFE bypasses were put in for claudication in the 60s. And I think we slowly learned that that wasn't a very good idea, and I certainly have at least one patient, which I still remember, where I started off with a PTFE bypass for claudication, and I ended up with an amputee who had to give up work. So that was a big message to me, and it was a wake-up call. So different countries went different ways, but in Britain, because we don't like operating, we don't like working, we moved towards a more conservative approach, and there was a lot of information that came out of, and is still coming out of Britain, and to a certain extent from Scandinavia, on the value of exercise treatment. Now, there's exercise, there's been randomized trials. I mean, the College in Oxford did a randomized trial, the Sheffield trials from Beard, and using Nordic poles, the walking poles, there's still trials coming out showing that these can help as well, and that giving people advice on exercise simply isn't enough, because you get somebody who waddles into the clinic, all they want to do in England is drink beer and sit on a couch and smoke their cigarettes, and the only thing they have to do is to get round the corner to the pub to go and have their beer, so they're never going to take exercise. So that's where the whole idea of the exercise program falls down. But in motivating people, it certainly is shown in randomized trials to make a big difference. And in the trials at a year, it is more effective than using a balloon dilatation for a superficial femoral artery stenosis. So that the exercise is better than treating with a balloon in those trials. The other thing about that, because of the National Health Service and we had waiting lists and everybody has to wait for their operations, it became apparent that you don't need to operate on claudication the first time they come in to the clinic. And I worked in Boston for a year and made a lot of friends and thoroughly enjoyed my time there. And some of those friends went to work in various places around the United States. And you asked about their practice data, and they were operating on claudicants who'd only been claudicating for a week or 2 weeks. And I said, that's crazy. What do you know, why don't you wait? Why don't you see what's going to happen? And they said, John, if I wait, they'll just have an operation by the surgeon next door, so I might as well do it. And that has driven this rather aggressive approach to treating claudication early. Because what we found, and I'm sure many of you have found, that if you wait 3 months and you say, look, go away and exercise, for goodness sake, stop smoking, see how you do, and in 3 months' time, if you are incapacitated, then we will consider intervention. But until then, it is very likely that all you've done is block your superficial femoral artery, you're going to develop collaterals, and you're going to be fine. And if we do that form of management, then a lot of these people avoid intervention. And as we heard, I think in almost the first talk this morning, about 90% of these patients don't require any intervention at all. But perhaps, which we've also heard this morning, so I'm just reiterating what other people have said, medical treatment is probably the most important thing about the claudicant, because the one thing that is vital in the patient that presents to the clinic with claudication is to recognize that that patient is at high risk of ischemic heart disease. It is much more important to investigate their heart, do a stress echocardiogram and so on, than it is to do their Doppler pressures. You can feel the pulses, they're not going to have a foot pulse because they've got an SFA block and they've got a perfused foot, so you can afford to wait on that. But what you can't wait on is the fact they may have occult coronary disease. And if we as vascular surgeons get focused on the leg and we're not treating the whole patient, then we're not doing the patient a service. So it's very, very important at that early stage to look at or consider coronary artery disease and refer the patient to a cardiologist. There's also the forms of medical treatment, and we all think that all our patients are on antiplatelet agents. We think all our patients are on antihypertensive treatment, and we think all our patients are on statins. And we did a study at St Mary's, we didn't publish it, was just for the trainees, on how many of our patients, all our patients are discharged from hospital on triple therapy, every single one, obviously, because they all need it. But actually, when you come to look at it, for various reasons in terms of actually prescribing the drugs and follow-up, by the time they come back to their first clinic, only 70% of them are still on